interested to hear other examples that the rest of you have. As far as what you noticed about how the article was written, the directionality of it, it was intentional. I wrote this for a medical journal. There's another side of that story too. I can go back to the early 1980s when I was getting my MPH in Chapel Hill, North Carolina. I was in health behavior, HBHE. And I participated as a kind of a graduate student assistant in what was then called the Churches Project. It was a project between the UNC School of Public Health and the General Baptist State Convention of North Carolina, which was the NBC, which was the denomination in the state in Raleigh of the NBC Baptists, the African American Baptists. And this was a program. This was one of really the very first broad-based, church-based health promotion programs that ever existed. Began in the 70s. And in this instance, the medical care providers, physicians, nurses, nurse practitioners, other healthcare people, allied health people, worked with the local denomination with its regions or sections, I don't remember how it was divvied up, and local churches to strengthen church congregations to be able to serve as primary care clinics and provide services to individuals and help pastors and churches meet the needs of their congregants. So I mean, it's I'm not sure which direction. It's kind of the way that you described it. It's kind of both directions going on there, but it's not so much hospitals or medical care institutions saying how can we use the churches to meet our ends. It's both institutions saying how can we work together, how can we further the health of the community and the health of the public, and at the same time how can we help establish a new domain of services that can help strengthen these church communities. So this was my first exposure to any of this. Interestingly, take a little historical tack, this whole idea of partnerships between individual church congregations and denominations and medical care institutions at a local level to work through churches to attend to the medical care needs of populations that spawned the UNC program and all the hundreds of programs. In fact, the stuff written about in the other article that you read, the Campbell piece, which is very good, actually its origins was in, as far as I know, was through the work in the early 1970s of Granger Westberg. And actually there's two connections with Westberg. His holistic health care centers, which were I believe, was Westberg a Lutheran? Okay, there's a product of his Lutheran ministry, and this was, to my knowledge, he invented holistic healthcare clinics. He invented church-based health promotion. And here's something I bet even George didn't know. Prior to that, he had been in Houston, where he had been a faculty member of, at the time, the Baylor University College of Medicine, and established and taught the very first medical school class on religion and health that was ever taught. This is like 55 years ago, and it was taught at Baylor. And this is something I only just discovered the last 2 or 3 years. He then moved to Chicago, where he invented holistic healthcare and congregation-based health promotion right there in Chicago. So this conversation has been going on a long time. Chicago was kind of ground zero for a lot of it, there are programs. To me, the church-based health promotion programs and community-based congregational programs, I think, are the best example I can think of, Kristen, of what you were getting at, of things that aren't just so one-directional, of medical care institutions or the medical care profession saying, how can we use these guys over here to further our ends? Which, I mean, I appreciate that, and I'm speaking so generally, I appreciate that people would want to reach out to the faith community, but it is very one-sided, and I think there's all kinds of jurisdictional and turf issues and power issues and gendered issues and all kinds of things that come into play there. But I think also that there's that there's potential for more of an equal partnership, and that both sides, and I hate to use the word sides, but both parts of this endeavor can find something to gain to further each of their respective missions. On religion and health that was published in Preventive Medicine. That's the reason I sent my paper to this journal, because he published there 40 years ago, is I think one of the truly essential pieces that was ever written, and as much, and if those of you with an interest in it, I don't recall if it's in your syllabus, it's about a 40-some-year-old paper, but it essentially was a series of points of intersection and questions, all the different ways that religion or faith or spirituality or prayer or belief systems or value systems and so on could influence health behavior. And it's a fascinating paper. It's never been duplicated, and I still assign that paper. It's dated, but it's not outdated, and it's as nice a discussion of these kind of conceptual issues as anything that's out there. Very good paper. Points that I alluded to, at the beginning, that these partnerships, again, using more of a policy language here, that these partnerships have mostly always been in place, and were originally the function of religious institutions and churches. And it's only really in the 20th century that these things, that the care of people, not just at the end of life, but the beginning of life and throughout life, kind of got medicalized and divorced from its roots as part of the ministry to people in need. And so I think, I guess we're coming back to that. I think maybe we're coming back to awareness of it. It's always existed. If all of these medical institutions are religiously branded and were started by religious organizations, then they were always doing this. I wish I could find a more lucid way to express this. I think that that end-of-life care has always been. When was it not a partnership between the faith sector and the medical sector? Probably when you go back far enough, and the medical sector wasn't even a piece of it. So the faith sector has always been a piece. And for those of you who are, I guess all of you who are chaplains or chaplains in training or in pastoral care field, this isn't some new thing. This isn't some new innovation. This is part and parcel of what you do and what you've always done. And I guess as a profession, it existed for 90 years, 100 years, whatever it is. But religious institutions and religious people have always been providing this care. And I've talked about hospitals a lot. Go back to the middle of the 19th century. Go back almost 200 years, little less than 200 years. The nursing profession. Florence Nightingale, the nursing profession was itself an outgrowth, an externalization of the prophetic ministry of religious institutions. And there was a reason that historically in the 19th century and still in parts of Europe, nurses were called sisters. It was not for gender reasons, because so many of them were religious. There were nuns. And again, I struggle to try to find a way to tie this together better. But again, I do not think that these sorts of partnerships are anything new, and I would maybe contest the idea that this is coming back. I don't think it ever went anywhere. But I think to the extent to which medical care institutions and academic medical scholars and other scholars can come to a realization that they've always been in partnership and should continue to be in partnership and should strengthen these partnerships, I think that's a good thing. And so anything that any of us can do to raise awareness of this is positive. But one of the things I alluded to in the paper, or I didn't allude to it, I think I said it really strongly, is the issue of these jurisdictional battles. In our society, medical care sector is very strong, it's very well connected politically. It's got the money, it has the power, it has the authority, and religious institutions, at least in the medical setting, less so. And I think there's some danger that the values, the prerogatives, and so forth of the of the medical care world will come to dominate and define the work and functioning of the other sector, you guys. And I think that there's some reason to be nervous about that. Of course, these issues have been dealt with and adjudicated and negotiated for years and decades by now. This isn't anything new, but I think there's a power differential here that if it gets more out of control than it is now, I mean, only mischief could come from it, and I think it's something to be concerned about. You look at the history of medical ethics as a scholarly field, not the history of medical ethics. There's been medical ethics, even if it hasn't been called that for 200 years. But as and the Catholic Church has had a mechanism by which responsa are written, just as within Judaism, there have been what we call shuvot, or responsa to medical care questions have existed for hundreds of years. People pose questions to rabbis, the rabbis respond. These are compended. The Orthodox and conservative and reform movements or denominations have their own compendia of halacha or Jewish law applied to medical ethics questions or bioethical questions. At any rate, so this has existed for a long time. But as a field qua field, as a scholarly field, I don't think that medical ethics goes back much before the 1960s. And in fact, as far as I can tell, it's often credited as the birth of academic medical ethics was the dissertation of the late Lord Rabbi Dr. Emanuel Yakubovitz in 1959, the year I was born, in Michael Reese, Jewish medical ethics. And subsequent to that, there were professional societies founded, and there are now centers at medical schools. There are ethics committees, and all the trappings that exist. Religious prescriptions and proscriptions, religious values have thus, as long as there has been a field of academic bioethics, religious, heavy quotes around religious values, decision-making has informed medical ethics. Not in the same way. Different belief systems assert different things about different clinical situations. I'm at Baylor. Medical ethics informed by pastors who are members in good standing of the Southern Baptist Convention when it comes to issues like end-of-life care, reproductive medicine, and so on, are going to be a little bit different than the decision-making of Reformed Jewish rabbis or Congregationalists or disciples, ministers, and so on. So, I mean, I think this is understandable. But as long as there has been a field of medical ethics, clinical medical ethics, religious values have influenced, one way or another, the sorts of decision-making that goes on. Now, the other direction, I don't know if this is the way he intended it, but at least in the Jewish medical ethics world, the Jewish bioethics world, with the increasing proliferation of new medical technologies, there has been a need for the sorts of people who in my tradition we call post-scheme or rabbinic decisors. There's been a need for them to sit down and reason through the way that they do, drawing on the scriptures and traditions and the Talmud and what have you. And in the Catholic tradition, it's the same way, although they're drawing on different sources. There's been a need to draw on these traditional sources, these great fonts of spiritual wisdom, to come to decisions that to place parameters around how we are going to intersect with these technologies. So, for example, if you go to some of the great texts of healthcare ethics in the Catholic tradition, Roman Catholic tradition, and the Orthodox Jewish tradition dating back earlier in the 20th century, there was not a whole lot about xenotransplantation and about life extension and about what have you, because these things didn't, in vitro fertilization, these things didn't exist. So now because of these technologies, the bioethical and medical ethics traditions have needed to reason through how we're going to deal with and cope with these phenomena. And of course, different belief systems, different denominations do this in different ways. A book I don't have it with me in the office, it's at home, and you probably could find it. It was a wonderful book. It was something like 6 major religious traditions reflect on medical ethics. And it was a Catholic, Jewish, Hindu, Buddhist, Muslim, and perhaps some sort of generic Protestant. I don't recall, but it was fascinating, and it looked at abortion, euthanasia, birth control, so on. And it was fascinating to read through this and find the extent to which there were similarities across faith traditions and very significant differences. So I think the arrow works both ways. I think that faith traditions have influenced medical ethical decision making, but I think that the growth in medical technology has influenced the terrain over which medical ethics commentators, especially from the religious end, what they comment on. In the context in which you asked the question, yeah, I'm an epidemiologist, and the research that I personally have been involved in, for the most part, has been population-based studies looking at effect of religious behaviors and beliefs and so on rates of morbidity and mortality. Again, as I said before, probably the least exciting intersection of all of this, and in some ways the least exciting of all the empirical research that's done in this area. I think a trend that I've seen, and the question that I asked in the paper was very simply, what works and what doesn't work? And I think this is vital. We have, we're going on 45 years now of these church and congregation-based interventions and these partnerships between health departments and congregations and these community-based interventions and so on. But there's been negligible evaluative research, negligible program evaluation and evaluative research. And I don't remember if the Campbell piece went into that detail. It had a little table where it listed some of the programs in which we'd evaluate and weighed information. But out of the hundreds and hundreds and hundreds that have been out there, there's very little. So I think that, I don't know if this is so much a trend, but it's definitely where the basket in which I would put the most eggs. We need to do a better job in figuring out what works, what sort of interventions work when it comes to congregation-based health promotion, not just health promotion. Back in my, I was at Baylor, my prior life in the 80s and 90s, I taught medical school in Virginia, a small medical school in Virginia, in Norfolk. And it was just across the Elizabeth River from the National VA Chaplains Training Center. And I got to know, I don't remember, at a conference somewhere, I met the gentleman, I forget his name now, 25, 30 years, who was the director of this. He was the research director of the center. And so I started going every 6 weeks for a couple of years. I would go and give a lecture to the incoming cohort of people training to be chaplains in the VA system. And every time I went there, the gentleman who was the head of the program and so many of the chaplaincy students in the class kept saying the same thing: please do some research for us. Somebody do some research. The pressures within the VA system to cut us, to cut our budget, to cut our personnel are driving us nuts. And everything now is moving in an evidence-based direction. Outcomes research, evidence-based, and please, anything you can do. And it was just, and it pestered me to no end, but I was completely, I had NIH grants. My time was committed, but I did my best to try to connect them to certain people. There was a researcher, I think, in New England. I remember, again, from 25 years ago, Elizabeth McSherry, who worked in Dave Larson's cohort, and I think she was doing health services research. And I haven't run into her in 25 years, but I don't know how many people were out there in that system that were capable of doing this kind of work. But I think there is a need, not just, believe me, if the epidemiologic research on religion, if that petered out and we're just stuck with the 6,000 studies we have, the world will keep the world will go on spinning. but I think we're in desperate need of program evaluation and evaluative research, and that includes both formative and summative research. It includes impact evaluation and especially outcome evaluation, if you guys know that terminology, on faith-based work, both interventions in congregations, public health interventions in communities, and the work of faith-based professionals such as pastoral care folks working in healthcare settings. We need all of that, and they're just relative to the basic research and the epidemiologic research. It's negligible. I mean, negligible is harsh. I mean, there have been some good work done, but it's, I mean, I think if you counted all the good evaluations that have been done, and on all of this stuff put together, I don't think you'd hit the number 20. I don't think you'd get that far. So that's where I think we need to go. And of course, this is contingent on funding. Is NIH going to fund all of this stuff? I don't know. They might be a little nervous about the topic. And frankly, the whole world can't keep going to the Templeton Foundation for funding. They only have so much money. I think Robert Wood Johnson at one point was funding something in this area, but that might have been years ago already. So there's, it's easy for me sitting here in my ivory tower in Baylor and saying, there needs to be research on all of this, and we need to be doing X, Y, and Z. But without funding, it's not going to happen. Now, I think some of the different denominations have funded research on the broad intersection of faith and medicine. The Presbyterians were funding research back in the 90s and 2000s. United Methodists Health Ministries, or whatever that entity is called, nationally was funding some stuff, but I don't know. But that's what I would do. That's where I would put my focus. Maybe you want to say something more as far as chaplaincy. What I remember, there was that meeting I went to in Washington that Keith Metter put together. I think there was an ongoing project, or still is, with Templeton to I don't know if that's to jumpstart research or to jumpstart training or whatever it was about, but I don't know. Maybe you here at Baylor, and but before I was a medical scientist, actually I was a religion major too. I trained as a religious scholar, and I thought I knew something about religion. After 9 years here, I find out I know less about Baptists than I thought, and I keep finding out I know less and less. It's so confusing to me. The American Baptists, different types of National Baptists, Southern Baptists, and then the Southern Baptists have cleaved. There's the CBFs who've broken off, and then there's the Alliance Baptists, and then there's Texas Baptists, which are their own world, and all these little elements are fighting. I don't have a clue. I don't even know what the Baptist world is. It's pretty complex, but probably not as complex as the Baptist world. And as far as the deep pockets, I wouldn't have a clue. We are at the Institute for Studies of Religion here. We're always looking for donors, and we're still looking. It's hard. But yeah, what you said, the denomination-wide, the idea of some sort of a spiritual ministry or spiritual care entity, that's been talked about. But what Baptist group? They're all, the American Baptists don't have anything to do with the Southern Baptists, and then the National Baptists are their own world, and then at the National Baptist USA and National Baptist America, they're oil and water. So it's an unusual world. But actually, this matters because this is the largest. Overall, this is the largest denomination, meta-denomination of Protestants in the United States, by far. Nothing else is even close. So what happens in the Baptist world, in some ways, drives what can happen elsewhere. But you got me. I know the Methodists have been on, the United Methodist Church has been on top of this for a long time, but that doesn't mean that they are spending millions of dollars funding people to do outcomes research. My sense is that each major denomination that sponsors that has a healthcare system could and should be ideally funding their own evidence-based outcomes research. I mean, it's in their best interest. They don't need an outsider to come in and say, please do this so that we can do research and write papers and learn about religion health. For their own purposes, they should be doing this. And I don't know why to some extent this isn't going on. But maybe this needs to be communicated in the boardrooms of these denominations, because they have the money. They have the money. Fund research that, you know, basic primary data collection or secondary analysis of existing data on religious questions. Actually, I was the first person ever funded. This is a little not quite Granger Westbrook, but a little known fact. In 1989, I wrote an R29 grant, a 5-year grant. I was the first person ever funded by the NIH ever to do empirical research. And this was, and there was the issue of the religion and state. None of this ever came up. I was looking at existing data sources like the General Social Survey, which was done out of in Hyde Park, out of the U of C, and other data sources from Michigan or elsewhere. There just happened to be some questions on religion or spirituality in the data sets. But I was funded through the National Institute on Aging as part of their minority aging program. And many people have been funded. Neil Krauss, Robert Taylor and the Chatters, Alan Neither, others have been funded. There's nothing prohibiting the NIH or even the National Science Foundation from funding research that looks at issues of faith or spirituality. But what it will not do is fund stuff that's not specifically, narrowly contexted to enable us to obtain information that tells us about things like morbidity rates, mortality rates, life expectancy. It's very much what we were talking about at the beginning. It's religious data in service of medical ends. So whether the NIH, one can apply for an NIH grant to evaluate programs providing spiritual care. I don't know. I don't know if anybody that's ever gotten a big grant from the NIH to do that. But there's nothing that forbids them from funding research on religion as long as it's part of the larger medical enterprise. In fact, the first NIH conference on this topic was, I think, in 1995 in Washington. It was a big event, and there were theological scholars and doctors and epidemiologists and anthropologists and soc and psych and chaplains and social workers and everybody else, and they produced a big report. And so this is, the faith has made its inroads into the NIH, but unfortunately not to the ends that I think we're talking about here. Again, if you want to do a big epidemiologic study, you can apply for money and see what happens. But this stuff's a little different. And this is why I said I think that the foundations, if they have money, or the religious denominations are the place that are going to underwrite this kind of value for research. The first point about, which I think is very well taken, that there are certain populations, groups of people and populations that are in a constant state of being overstressed, constant of arousal, and this can have devastating effects as far as immunity. I am of the opinion that the rash of mysterious, possibly unexplained autoimmune diseases that we see might have something to do with this. It's like the body is in a, I'm making a fist, it's in like a constant state of I don't even know the language. My wife, incidentally, Dr. Lee Steele, is also an epidemiologist, and she is an expert on chronic fatigue syndrome and fibromyalgia. She coined the phrase Gulf War illness, and she is of the opinion that there was a kind of hypervigilance or hyperarousal, or that can have devastating effects. So then that makes all the sense in the world. I also think that if that's the case, this could impact on, for example, this could both impact on providing driving people into use of opioids or abusing opioids, and at the same time, perhaps physiologically or pathophysiologically, for reasons that are above my pay grade, can impact on their becoming more addicted and being in becoming more difficult to release taking these without without going into severe withdrawal. So I think that there's something there's something about the hyperarousal state, and this can be due to a degradation of our physical environment. It can be due to racism or oppression or other isms. It can be due to all the other kinds of offenses and aggressions and stresses that bombard so many of us on a daily basis. And for some of us, for whatever reasons, our bodies just end up in a certain state that I think creates vulnerabilities. So then, are there pathways, or are there institutions that can help mediate between all of these stressors and this state of hyperarousal and the negative outcomes that can accrue in our bodies, whether due to things we take to medicate ourselves or not? Well, yeah, certainly. Can churches fill this role? Certainly. Why not? I would direct you to another one of my papers from, if I remember, 1984. So this is going back a lot. I was just a kid. I was just fresh out of college. I wrote a paper called, it was published in the Journal of the NMA, the National Medical Association. It was like it was my first authored pub, and it was an effort to review the literature on all of these studies of church-based health promotion programs and pastoral health promotive messages and all of that. It was called and I don't remember, something like the role of the Black church in community medicine or something like that. And then a year later, I published something in Pastoral Psych on, I think, the role of the Black pastor in, I don't remember the title, preventive medicine. This is 30 plus years ago. But if you find those two papers, they make the case. As well as a 25-year-old can make the case, fresh out of college, that there's something here, and that these institutions, there's evidence that these institutions can help provide services and thus potentially mediate what some epidemiologists would call the socio-ecologic stressors that bombard people. Okay, now the thing that you said, first of all, about physical and mental health and all the different domains and leukocyte telomere length and all of that, there's actually two interesting points here. There has been some research in the last, I don't know how many years, 2, 3, 4 years, on religion and telomere length, leukocyte telomere length. There have been a couple studies, one by Hill and one, I forget who the other one was by. I know Chris Ellison was part of one. And then there was a response by Tyler Vanderweel of Harvard, who has written on this. He's an epidemiologist / biostatistician at Harvard School of Public Health. So there's actually a literature now on spirituality, that's a very inexact word, on religious participation and telomere length. And just as the things that you mentioned, it appears that positive religious participation is also a protective factor as well. And that is also associated with longevity. And there have been dozens actually of really sophisticated studies linking religious participation to longevity, epidemiologic sorts of studies showing increased survival rates, studies done at Berkeley, studies done at Michigan, studies done at Duke, Texas, all over the place. And so now here was an effort, these leukocyte telomere length studies, to link this down to the cellular level, which is really interesting. So there's a literature here. And then the other thing I wanted to say, there was a name that I mentioned earlier, Keith Metter, who is also a colleague of George's. Keith is at Vanderbilt. He was at Duke. He's at Vanderbilt. And they have at one time, a couple years ago, I don't know if they still do, the largest database for personalized medicine that exists in the world. And they have, like, their sample is like 100,000 people that are seen in that practice in Nashville at Vanderbilt. Every data point for every visit they've ever had, every medical test that they've ever had, as well as genomic data, which is just unbelievable. And Keith, they were seeking funding to fold in psychosocial assessments and spiritual assessment. And I know they had applied for some money from Templeton a couple years ago, and they didn't get it. But I don't know if they've furthered that. So the potential is, and I don't remember if there's any of you at Vanderbilt, but they will have, if not already, a database that links personalized medicine data, genomic data, I call it that, psychosocial data, data on health services use encounters, and potentially spiritual assessment as part of the intake for every single individual or some large subset of individuals in that database. So, holy cow! I mean, I think if your interest is evidence-based outcomes research on all of this stuff, especially its integration, Vanderbilt is the place to be. But I don't know where they are in this process right now, and that's all I can say about that. But when you were saying that earlier, that's the first thing I thought of was what was going on at Vanderbilt. And I would suggest, I mean, do a PubMed search or a Google Scholar search or whatever, and look up Keith Metter and look up Vanderbilt and see. Maybe this is further along than I know. Had they gotten that grant, I was going to be a consultant on it, but this was 2 or 3 years ago, and the grant wasn't funded. I'll answer that. There's kind of two dimensions of this. As far as epidemiologists that look at the intersection of religion and health, we've got two of them here, Georgia B, and then there's a guy named Bill Strawbridge at Berkeley, and Tyler Vanderweel at Harvard. There's not a whole lot. Most of the people who since the 1980s have been doing the basic research in this area have been sociologists, and mostly sociologists, and then a few psychologists like Ken Parkman and Linda Chatters and a few others. But if you're talking about card-carrying people with advanced degrees in epidemiology, I'd be hard-pressed. I would say not received well at all. Now, I am a member in good standing of the American College of Epidemiology. I had to be voted in, so that's good. But they haven't made me a fellow yet, so I don't know. Maybe they're telling me something now. But that's epidemiologists. Now, as far as academic physicians and medical sociologists and health psychologists, I think there's tremendous openness, and the terrain here is not at all like it was 25 years ago or 20 or 25 or 30 years ago. For anybody who can remember back that far, the late Dave Larson, who was one of the, along with Harold Koenig and myself, were kind of, and Ellen Eidler and Ken Parkman, were kind of there at the beginning of this, back in the early 80s, mid 80s. He once famously referred to this topic as the ATF, the anti-tenure factor, in a chapter of one of my books 25 years ago, and meaning that for anybody in the medical field or the medical world or a professor or whatever to even engage faith or spirituality or religion, you were taking your career in your hands. So he called it the anti-tenure factor. It's funny. I was just with Harold Koenig. Was it last week? At Duke, and we were talking about this, that there was back in the 80s and early 90s kind of a first generation, a group of people, maybe 10, 12 people at the most, who were doing this kind of work, who were doing the research. Larson and Koenig and me and Eidler, Chris Ellison, maybe some of these names mean something, Linda George, Neil Krause, George, Keith Metter, Ken Pargaments, I'm leaving David Williams, pretty much a core group of people. And now, step ahead all these years, almost every single one of us almost is either has an endowed chair or distinguished chair or named chair, or is the director of a center or a program or an institute, or is a department chair or something. So the positive sense of all of this is that it hasn't interfered with our progression. I won't say that any of this is mainstream. There's still a marginality to it, but I think that these centers and programs are allowed to exist within academic medical institutions, and people can do this work and advance their careers. And as far as you guys, the healthcare chaplaincy profession exists. It exists. There are jobs. People are doing their thing. So, I mean, for a lot of us who were part of the research end of this for 30, 35 years now, 40 years, there's a sense of being beleaguered. And like, oh, we've just been beating our head against the wall for so many years. But out in the real world, I mean, maybe there's a little more acceptance of this, or or ability for this whole segment to go about its business than we realize sometimes. And even the empirical research end, it's doing fine. It's doing great. So I think, are there fewer barriers now than there were 30 years ago? Of course. And I think I think things will continue to move in that direction. One of the things that's been very important has been the rise of what's now called integrative medicine. So that it used to be holistic health, and then it was alternative medicine, complementary medicine. Now it's integrative health is kind of the buzz phrase. And that whole domain has adopted spirituality as one of its core kind of foci. And so a lot of us, without intention, have kind of been read into that world. So I've kind of been read into that world, and they're very positive. And there are integrative medicine or complementary medicine centers at almost every academic medical institution in the country and medical school. And so that's another conduit or pathway by which spiritual topics or subject matter can insinuate itself into the larger discourse within medicine. And it's doing, and yes, is there resistance? Of course there is, but it exists. If 120 some medical schools in North America have coursework or clerkships on either spirituality or alternative medicine, and this wasn't, and the number was 0 25 years ago, then something's happening. Anybody that's interested in all the research stuff, I've written zillions of papers, but there's a paper I had in '96, and it was in social science and medicine, and I forget the name of it. It had the word host resistance in it, and it was kind of my model. And the information in it is a little outdated, but if you want to find kind of my thinking on how the mechanisms that connect all this, go to my host resistance paper in '96 in social science and medicine.